I'm Carole Taylor. On this edition of Journal, we focus on the rural-urban divide in healthcare. Mayor Goetz has spoken movingly about the stress in his community of Merritt caused by the intermittent, unpredictable closings of his hospital's ER. What do you do when your emergency department is closed and the next nearest is maybe 100 kilometers away? How many times in the last year have we seen these temporary closures in headline after headline, affecting hospitals throughout BC? And it's not just ER closures. We've also seen pediatric care in Kelowna under threat, as well as maternity care in Kamloops and Prince George. It's as though we have come to accept the current state of healthcare delivery as the new model. And there are other issues. If your rural hospital can't do complex operations and you must travel to a city center, well, who pays for those additional expenses? And it's not just travel costs, but also hotel stays if the procedure requires extended care. And doesn't the Canada Health Act promise reasonable access to health care wherever you live? Dan Levitt, BC's seniors advocate, also raises the issue of long-term care in rural communities. Where do you go if your community just doesn't have these services? Working on all of these issues is Paul Adams, the Executive Director of the BC Rural Health Network. This network brings together more than 30 rural municipalities, several regional districts, and more than 70 nonprofits to focus on needs and possible solutions. He believes this rural-urban divide has gotten much worse since COVID. So what can we do about it? Paul Adams joins us after this break. Paul Adams joins us now, and it's interesting when I talked about all the areas of the province that have some healthcare issues. You're right in the middle of that. That's why the network has been built, is it not?
It is. You know, we have challenges all over rural and remote British Columbia, from Haida Gwaii to Fort Nelson, onto Vancouver Island, from Port Hardy and everywhere in between. So the need of a network and bringing voices together in order to create better policy for rural health is critical.
So how's it working?
Well, I am hoping that we're making an impact and that people are hearing what we have to say, and I believe that is the case. But it's challenging. You know, it's a huge mechanism, and we've had decades of decline in healthcare provision across the province, and you know, it's going to take a lot of effort to make changes for the better.
Do you think the rural areas are hit harder than the big urban centers?
Well, they are. You know, we went in through a process of central regionalization, and that really started back in the 1990s. And in doing that, you know, we've removed a lot of services from rural communities.
Can you give me an example?
Well, for example, my oldest son was born in 1996, and that was the first year that we couldn't deliver babies in our community. And prior to that time, we had a general surgery, we had maternity care, we had 21 acute beds, and we had basic, you know, we didn't have high-level specialty care, obviously, and we weren't doing brain surgery, but we were, you were able to get an appendectomy, or you were able to deliver your baby within community. And when we centralized services and we brought those into large urban centers, we also created a situation where recruitment and retention was difficult because people weren't able to practice to their scope of practice. And so people who had skill sets and they wanted to work in rural ended up working in smaller urban centers rather than in the small town hospitals. So and we've seen that, you know, continue to deteriorate over since that mid-90s period all the way through till today.
And so in losing not just the hospital, but you lose that leadership in your community because those people go to where they can get jobs.
Right, and you lower the skill set within the community. You now have nursing staff that don't have the anesthesia training, or they don't have those higher level skill sets. They're moving out, And at the same time, we weren't just centralizing healthcare services. Then as we moved into the early 2000s, we started centralizing everything. So it was highways, it was forestry, it was conservation, and it was the removal of really those community leaders from rural BC. So you started losing that fabric and that leadership component within the small town environment. And I think that, you know, we are starting to recognize that even though the austerity measures, and it makes sense from an economies of scale perspective, that it doesn't really make sense from you know, how we need to grow a society broadly, and that you know, when we start marginalizing people and marginalizing communities and making it more and more difficult for them to reach care, that becomes a huge challenge. And that happened with transportation in a big way as well. So reaching care was a big problem.
So what is the answer, to go back to a more decentralized healthcare system?
I think, you know, there is a certain element of decentralization that needs to happen. I don't think that is the moves that were made to bring high-level, high acuity care into urban pockets. It makes a lot of sense. But we need to take the lower acuity pieces, provide those within local community. And for example, you know, we've demonstrated there is a lot of research that demonstrates that small surgical centers have as good, or if not better, outcomes than large urban centers from a low acuity perspective. So then we can start bringing people to those facilities from large urban centers and reverse the process, which is an economic boost for those communities, bringing people in to have, you know, maybe it be a hernia repair, for example. And that type of service will then boost the local economy from people coming into the community, and people given an option. You know, you can wait, or you can go and have your procedure done in a smaller rural location. And bolstering services, but also making sure that people can reach the service. So, you know, we have this huge inequity that takes place where in rural BC, for a single diagnosis, the average out-of-pocket cost for an individual, a resident, is over $3,000 to have, you know, what you would expect from a public universal healthcare system. So if you don't have transportation options, and, you know, with the cost of accommodation out of town, all of these things compound, and that $3,000 per diagnosis is, you know, further heightened if you've got something serious. You know, if you're looking at transplant procedures in Vancouver, some of those costs are in the multiples of tens of thousands, and people have to stay here for 3 months with a care provider post-surgery, and, you know, we're looking at $1,000 a night room rates for FIFA next year. So we've got all of these escalating challenges that compound upon people who really don't have a choice about where they live. It's not an option. It's a reality where we work in and live and play in the communities that we do. And usually it's because of the fact that we're involved in our resource sector, or we're involved in agriculture, or we're indigenous, or any number of different factors. So people live where they live, and we need to provide that service. In fact, it's a requirement under Canada Health Act. Section 12(1)A is,
But no one's paying attention, Paul.
No, but we have to hold feet to the flame. And again, it's not a political piece. It is political, but it's not a partisan piece. It bridges political lines. We need to come together. We need to solve the health crisis that we have through agreement. And I think that the only way to do that is having these conversations and making people aware of some of the inequities that do exist.
So do you have numbers? You're always doing research, but do you have numbers that will paint a picture for people who are listening to this about how bad it is in rural communities versus urban?
Sure. So a great example, Vancouver Island. So if you live on the north end of Vancouver Island, your life expectancy is 74. If you live on the south end of Vancouver Island, your life expectancy is 82. So that's a pretty stark difference in life expectancy, 8 years based on one end of the island to the other end of the island. And I think that, it is those, it is the actual, the dynamics of health that go beyond just healthcare. It is those social determinants. So it's a combination then of the lack of transportation, the lack of access, and even the lack of people being willing to partake in the system. So after a period of time, you become disenfranchised and you no longer feel that you can afford to seek care. And so you don't, and your condition moves from something that's acute to something that's chronic, and then requires ongoing management and a huge cost to the system. If we look at alternative level care in hospitals, where people are being housed within rural communities instead of seeking the appropriate care, we're at a cost of $1,500 a day for a single bed. And these costs just compile, and so people who should be perhaps in a long-term care facility or getting treatment for their condition end up being warehoused in small regional hospitals, and that adds additional weight and pressure upon the entire system.
Yes, because my daughter's an ER doctor, but they call them boarders, and in the ER department, when they should be admitted to a bed, but there's not a bed available, so they're boarders in the ER department and halls and wherever.
And we've done the same thing. Again, we're looking at end-of-life care, we're looking at palliative care, and we have people who are being treated for those conditions in a hospital bed. The cost of that is enormous compared to that of a long-term care facility. So rethinking how we can build primary health care, how your initial access to care is more holistic and looks at you as an individual rather than an attachment number.
We'll continue this conversation in just a moment. Quick break. Paul Adams is here to talk about some of the complexities of healthcare in rural areas. I find that I'm a little bit appalled when I see pediatric unit closing down, for instance, in Kelowna, or time and time again, ERs closing. And I have the feeling that we're just starting to ignore it. We've sort of got a scar over the wound, and we're not moved by it the way we should be. I don't see the politicians doing anything.
Well, we've seen, again, we continue to see emergency room closures throughout the province, and we do hear about them when they occasionally occur within the Lower Mainland. So there was a closure this last weekend at Delta overnight. But the difference being that at Delta, you're a half an hour away from the next available emergency room, and the ambulance is going to transport you directly to that facility. A lot of the time in rural BC, the same time Delta was closed, 100 Mile House was closed, Oliver was closed. We have now a permanent closure of Tumbler Ridge emergency room, where it's now being renamed to being a triage center. Closes at 7 p.m., doesn't open again until the morning. But we don't hear about those stories very much. So Delta will get a lot of attention. And even if you were to show up at the emergency room in Delta, you'd find the doors are open. And there will be a nurse inside, and there'll be someone to give you advice, and there'll be the ability to triage you to the next facility. If you show up at a small rural emergency room, you'll find there's a closed sign on the door. And that becomes a huge problem for people, and it costs people their lives. So, we've had people die in parking lots around the province, going there in expecting to be able to seek care in a very challenging moment. And the door is closed with a closed sign on the door. And we're just not hearing about it, So we need to make people aware that these closures are not happening just every now and again. In the Lower Mainland, they're happening daily almost. Well, they are happening daily because we've closed hospital emergency rooms that should never be closed. They should be 24/7. And you can go to Port Hardy, for example, and the facility closes down overnight. And that is supposed to be a 24/7 operation. And the same thing has happened within the interior. It's happening within the north. And we had recent closures in Fort Nelson, and the distance for somebody. If you show up at the emergency department in Fort Nelson expecting the door to be open, and you self-ambulate, and the door is closed, it's a 4-hour drive to the next nearest emergency room in Dawson Creek or in Fort St. John. So these distances and the actual impact on people's lives is very real, and it does cost people their lives, and it's a sad situation.
So when you lay it out like this to the political powers, do they just pat you on the head and say, well done, good for you?
Well, I get praise for bringing the issues forward, but I also get a lot of personal frustration from, the message that is often conveyed back that, well, we're doing better than we were last year, or we're doing better than they did in the previous government. And so that's, and that happens. I mean, I've been in advocacy for a long time, and that is a cycle of behavior that happens politically, as we always go back and we blame the previous government, or we say that, we're doing better than we were doing. But, in measurement of lives lost and lives saved, I don't think we even have the data to understand where we sit. So we maybe have 25% fewer closures than we did last year in an emergency room. But does that really matter if you show up with your toddler and the door is closed and they have a high fever and you've traveled there yourself from out of community in order to reach that center? It doesn't matter to you. What matters is that the door is closed. So we have to do more. We have to change the dynamics that's happening. And we have a very centric process of looking at things through the eyes of nurses and physicians. And again, obviously, I have great admiration for healthcare professionals. My dad served 50 years as a general practitioner, 30 years as a small town physician in Princeton, BC. And in his work, he was the guy who didn't want to retire because he didn't want to leave his patients behind. But that dynamic has shifted, and people want a work-life balance. And we have a global shortage of healthcare providers. So we really need to fill those gaps with different skills. We need to start using our technologies to enhance care delivery. We need more people who have empathy and care on the front lines of healthcare, whether they have the highest level training or not. Somebody with empathy and somebody who has the ability to help you navigate the system is going to be a much better benefit to your overall well-being than having a closed sign on a door.
Are people in rural communities getting mad about this?
They are. Again, we see protests happening, and people, the organization, the BC Rural Health Network, which I lead, it came out of that protesty kind of movement of holding the sign and saying, keep my hospital open, or I need a doctor. And it was those small town groups that emerged, again, during regional centralization of services that were demanding their services back, that created people within community who stepped up and came forward. Now we've moved from there to being a solutions-based organization, and I present solutions which are supported by evidence from the lived experience, qualitative data from people who live and work and play in rural BC, from Indigenous voices, from people from every corner of the province. And then we support those solutions with research and evidence. So I work very closely with the UBC Centre for Rural Health Research and Dr. Jude Cornelson, and we really look at the nuts and bolts of what's happening on the ground. So when we come up and we say that there's a disconnect between policy making and the community voice, we support that with real evidence. And the number of people that we bring into a research survey demonstrates that 90% of the people don't think they're even communicated with around their health, never mind have any input on the actual policies which are being made. So we need to change that. We need to bring community back into engagement, and we need to bring them to the table, and we need to understand what it is that we can do in order to support their needs for a better health and wellness within society. With $36 billion going into our provincial healthcare budget, the only way we're going to ever reduce that amount is by making people well. And so to do that, we have to give people access to the care that they need.
So step one, if you were asking the government, step one, this is how we start down that road.
We start building out new models of care within rural BC. And again, I'm working right now on an initiative, and I've presented it, a draft version of it, over to Dan Levitt with the Seniors Advocate Office, and looking at how we can build, smaller scale long-term care facilities as being a central hub to a community, and then building out community health centers from that hub, bringing in things like community gardens, community kitchens, having outreach happening from, within one rural community out to surrounding satellite communities. We have 850 unincorporated communities that don't even get recognized within the system because they're not what we call, they're not a subsidized community. So because they don't have a physician base in it, doesn't mean that people don't live in it. And so instead of having everybody flowing into the urban center, we create rural hubs where we have a significant care facility where people from the surrounding area can travel to, but also where we can travel to them and bring services. And the old adage of an ounce of prevention is a pound of cure is true. And, so we need to start preventing things and getting people educated and using our high schools to train paramedicine and to bring people at an early age into the healthcare system and then have them, go up through it and advance them into so that we have people who live and work and play in rural BC working in healthcare in rural BC. And it's not just all urban focused. And there is, again, 20% of the population live where I live. And it's a matter of those million people also need healthcare.
Thank you so much for explaining the story of what's going on and making people more aware, I think, and perhaps encouraging politicians to pay attention to rural BC, especially with healthcare. Thank you for being here today.
Thank you so much, Carole. Appreciate it.
Back in a moment. I applaud the approach the BC Rural Health Network is taking to the gaps in healthcare that exist in smaller communities around BC. By bringing together disparate groups of people, including policymakers, to talk and share thoughts about urgent health issues, they are taking the first step towards solutions. I wish them well. Please let me know your thoughts on YouTube. Till next time, I'm Carole Taylor.